Thank you. And before I start, I'd actually like to give you a thank you from Ohio State University for inviting me. This is a candy called a Buckeye, which is unique to Ohio State University. This is a gift for you. This is a gift for you as a Now, if it was a diabetes session, I can't give him the candy, but this is lipid, so I can do that. What I'm going to talk to you about for the next half hour is the new lipid guidelines that were just published from the American Association of Clinical Endocrinologists. I put the link to the website for the guideline here on the first page, and it'll also be on the last page of the presentation. What I'm going to do is highlight some of the recommendations, and particularly two of the most controversial, but still running through the basic information of the guidelines. Just to give you a little bit of the background, we last updated this guideline in 2012. We did not update it in 2013-2014 when the guidelines came out that took away the targets and talked about moderate and high intensity statin. And the reason we did not is we felt that the targets were evidence-based. We also knew that there were new agents in development that were much more potent than anything that was currently available. The type 2 diabetes guideline was updated a year ago. It did still retain the concept of targets, but one thing I want to highlight is that it did not identify the fact that type 1 should be addressed separately from type 2, which I feel is very important. So here's the official opening page of the guidelines. Just to let you know, the chair of the writing committee was Paul Jellinger. I was one of the members of the committee, and my primary focus in there was to make sure that we addressed type 1 as a separate entity from type 2. I also went through and made sure all the recommendations with respect to women and PCOS were accurate. That was the focus I took. Now, just to remind you of how we do guidelines, we have a formal process. It's meant to be an evidence-based education resource, a practical tool not just for endocrinologists, but all other healthcare professionals, organizations, regulatory agencies. We have a total of 87 recommendations in this guideline. I will not go through all 87 of them, but just to let you know that 45 of those are grade A and 18 are grade B. All of the references have also been given an evidence level grade, and a third of them are evidence level 1, 137 are evidence level 2. And just to remind you of how that's graded, on the left is evidence level, which is used for the citations. The evidence grade is what's used for the recommendation. And the highest level is level 1 or grade A, which would be either a randomized controlled trial or a meta-analysis of a randomized controlled trial. Now, in terms of the ACE Lipid Disorders Clinical Practice Guideline, what I'm going to very rapidly is highlight 15 of the 87 recommendations, some of which have some small changes from what you might have seen before in other ones, and also just to highlight issues such as special consideration to women and children. So in terms of what are the risk factors for atherosclerotic cardiovascular disease, our first recommendation there is to identify risk factors that enable personalized and optimized therapy for dyslipidemia. So the reason I wanted to highlight recommendation number 1 is to show you what you see on this next slide, is where we address major risk factors, additional risk factors, and non-traditional. Under major risk factors, we do list stage 3 or 4 chronic kidney disease. Under additional, we don't just list hyperlipidemia, but we include small dense LDL, ApoB, and LDL particle concentration. And then in non-traditional factors, we include things such as HSCRP, LPPLA2, uric acid, and Lp(a). So I just want to highlight that as we're a little bit more expansive on our risk factors than you might traditionally see. And then in terms of the question is, how is risk assessed? The first recommendation we make to this category, which is recommendation is that the 10-year risk of a coronary event should be determined by detailed assessment using one or more of the following tools, and the ones we chose to highlight were the Framingham Risk Assessment 2, the MESA 10-year risk with coronary artery calcification calculator, and I'm going to come back to that because coronary artery calcium is something that is often not talked about, but can be very important, especially in primary prevention. Then also the Reynolds risk score or the UK PDS risk engine. We also highlight that if HDL cholesterol is greater than 100, you could decrease, 60, you could decrease a risk factor. And that when possible, it's ideal to use a risk engine that factors elevated triglycerides into it because triglycerides above 200 are associated with increased risk. So I mentioned about the MESA and coronary artery calcium. MESA is the multi-ethnic study of atherosclerosis. It's a study that enrolled over 6,000 patients who were free of clinical cardiovascular disease at entry, and then they followed them prospectively. One of the markers they followed was coronary artery calcium, or CAC. And they found that in this population of low-risk patients, that was actually the strongest predictor of developing cardiovascular disease. So their risk score includes your traditional risk factors plus CAC to predict a 10-year CHD risk. And I'd like to show you what that looks like. In the left side is total CVD events. On the right is what they called hard, MI, resuscitated arrest, or CHD, death. And in the front of this plot, you see the person with a CAC of 0. So they do have increasing risk with increasing risk scores. However, once you have detectable coronary artery calcium, whether in the range of 1 to 100, 101 to 300, or above 300, you have an increased risk, and then that increases with number of risk factors. So this is an important component of looking in primary prevention, including low-risk patients. And then to look over time, just looking at the coronary artery calcium by these three categories, what you see is that the risk starts to increase immediately, and by 5 years is highest in those with a score above 100, not just above 300, but above 100, and is dramatically increased by 10 years of follow-up. Now, in terms of risk categories, this is the next thing I want to introduce here and give you what's really the most controversial piece of this guideline. So we introduced the idea of low risk, which is no risk factors, moderate risk where you have 2 or fewer risk factors, and a calculated 10-year risk of less than 10%. Major high risk would be if you have a CHD risk equivalent such as diabetes, stage 3-4 CKD with no other risk factors, or 2 or more with a 10-year risk of 10 to 20. And then very high risk, which is those with documented disease, plus minus a risk equivalent, and a 10-year risk greater than 20%. We then introduced this category that we call extreme risk, and I'll highlight it further on the next slide. And this is someone with progressive vascular disease, including unstable angina that persists after achieving an LDL less than 70, or established clinical disease with diabetes, stage 3-4 CKD, and or heterozygous FH, or in those with a history of premature coronary artery disease. And this category was added based on clinical trial data that I'll show you, primarily from Improve It, but after we published it, the 4A data also supports this category. So in terms of knowing that we now have these 3 categories, 3 high risk, high, very high, and extreme risk, I want to come back to diabetes. And for the person with diabetes, the recommendation is that they should be considered either high, very high, or extreme risk. However, we separated out type 1 diabetes because not everybody with type 1 diabetes is very high or extreme risk. They should definitely be screened annually, but the key is who's at the greatest risk. And again, I pulled that out into a separate slide. People with type 1 diabetes who have any amount of albuminuria have an increased risk of cardiovascular disease. Someone with late onset, which we defined as after age 30, without nephropathy, but who is still uncontrolled after more than 5 years or has had a previous history of an MI, or during that 5 to 15 years have been uncontrolled. Furthermore, if they're insulin resistant with metabolic syndrome or have a marker of inflammation, such as an elevated HSCRP, you should then consider these to be either very high risk or extreme risk. And so we really wanted to highlight that this group needs to be treated aggressively and should not be overlooked despite their age. Now, why the albuminuria? What's so important about proteinuria? So this is a systematic review combining 29 trials over 100,000 patients with diabetes, over 500,000 years of patient follow-up. And looking from left to right, you see all-cause death, cardiovascular death, MI, and stroke. And all of these categories are increased when you compare the person in the light gray with no proteinuria to the person in the dark gray who had any kind of proteinuria. So the presence of proteinuria of any type is increasing your risk for any of these events. There's another very nice study that we quoted, published in 2010, that was a meta-analysis looking at all-cause and cardiovascular mortality based on estimated GFR or categorical albuminuria. And the top is those who actually had an albumin to creatinine ratio measured. On the bottom is if they just had a dipstick. And then on the left is all-cause mortality, on the right is cardiovascular mortality. What you see from all four of these charts is once the estimated GFR drops below 75, you have an increase in your event risk. And this is a very important point that I'll come back to in my next talk, whether you have preserved estimated GFR or if it's begun to drop. Once it's below 75, again, you have increased risk. This is across all diabetes, whether type 1 diabetes or type 2 diabetes. So coming back to the guideline and the original question of screening for risk factors and who should be screened, we wanted to highlight a couple specific categories and then issues by age. Anybody with familial hypercholesterolemia or a suspicion should be screened and should be screened aggressively. And you should think of this anytime there's premature vascular disease, which means a definite MI or sudden death before age 55 in men, 65 in women. This is a change in recent years. Premature used to be younger, but it's now 55 in men and 65 in women, and that's consistent across all the guidelines. Also, if you have elevated cholesterol levels consistent with FH. Anybody with diabetes should be screened annually. Young adults, meaning age 20 to 45 for men and 20 to 55 for women, we recommend screening every 5 years. Then if you move forward in age to what the committee decided was middle-aged, age 45 to 65 for men, 55 to 65 for women, then you should be screening at least once every 2 years in the absence of clinical disease. Older adults, meaning over the age of 65, you should consider screening at least annually, but personalize it to their underlying disease history. Children and adolescents are a little bit more complicated. We do have formal guidelines from the National Institutes of Health almost 10 years ago now that looked at this issue. And any children at risk for familial hypercholesterolemia, you should begin screening at age 3. They should be screened again at least once between ages of 9 and 11, and again at age 18, after which they then go into the category of younger adults. When you look at adolescents who have not been screened over the age of 16, they should be screened at least every 5 years, and as they move into being a young adult, you would continue every 5 years. And just to remind you about familial hypercholesterolemia, you can have a clinical suspicion with premature atherosclerotic cardiovascular disease. Consider at least heterozygous FH with your LDL is above 190, presence of tendons and xanthomas, a full corneal arcus, or family history of high cholesterol and premature disease. We use the diagnostic tools listed here, primarily the Simon Vroom registered diagnostic criteria, but often the Dutch Lipid Clinic. We like to use genetic testing, but we rarely get to do that because our insurance payers usually won't cover it. So it's usually a clinical diagnosis for us. In terms of prevalence and risk, The estimate is that it's anywhere from 1 in 160,000 to 1 in 250,000 individuals. Obviously varies by country because some countries do have a higher prevalence. Interestingly, the heterozygous FH prevalence is somewhere between 1 in 200 and 1 in 250. Now think about it, if you're seeing 20 patients a day, that means you're seeing at least a couple people a month who have heterozygous FH and may not have been diagnosed. So this is something to think about, and we've really been pushing people to screen for this and try to identify these people young and as early as possible. Now, moving forward in terms of which screening tests should be used, we still recommend a fasting lipid profile, realizing sometimes you can only get it non-fasting, but fasting is preferred. The primary target is still LDL cholesterol. And one thing I can tell you, while I'm talking about the ACE guidelines here, I can tell you that ACC and American Heart, excuse me, they have convened a new consensus conference. It's not public knowledge, it hasn't been announced, but there will be a new set of recommendations coming from ACC-AHA. That committee is once again chaired by Scott Grundy, and because of the introduction of the PCSK9 inhibitors and the ability to lower cholesterol, LDL cholesterol, to below 20 to 40, targets will come back in their next version. And as I mentioned at the beginning with ACE, we never got rid of the targets because we felt the targets were evidence-based. Again, LDL cholesterol is our primary target. We do include HDL cholesterol as one of our screening tests. We also include non-HDL cholesterol, which generally the target is going to be 30 above your LDL. We feel triglycerides are very important, especially in people who have insulin resistance and metabolic syndrome, and it's a reminder of your screening for metabolic syndrome and for type 2 diabetes. We also feel that apoprotein should be considered as a screening test, and specifically ApoB, that ApoB is sufficiently evidence-based that it should be considered to be part of your screening. And then additional tests to consider, I mentioned about coronary artery calcium from the MESA study. This is something I do quite often in my people with type 1 diabetes who are not sure if they want to go on therapy. Other things that can be considered is HSCRP, also called cardio-CRP, LPPLA2, not used as commonly but also evidence-based, and homocysteine, and again, especially in primary prevention, the carotid intimate medial thickness, or CIMT. Now, just to move on to a couple special categories, one of the ones we raised is women. What special considerations should be given to women? Atherosclerotic cardiovascular disease is the leading cause of mortality in women in the United States. Women's symptoms are often less overt and or atypical, so they're often ignored and there's a delay in evaluation and diagnostic testing, much less appropriate therapy, whether statins or taking someone to the cath lab, leading to the increased mortality. So we do recommend that people remember to screen women using an appropriate risk score such as the Reynolds risk score or the Framingham score. And then in terms of treatment options, they should be treated aggressively with lifestyle intervention and when appropriate pharmacotherapy. A couple of things we did include in the recommendations is that hormone replacement therapy is not considered a treatment for dyslipidemia in postmenopausal women and should not be considered. Now, what about children and adolescents? I mentioned a little bit about screening them, and it's actually something that should be screened as a child and adolescent. You don't wait until someone is 18 or 21 to screen them. However, screening should start younger if there's a family history of FH, whether heterozygous or homozygous. So in terms of screening younger, that's our recommendation number 17. And then as I mentioned before, recommendation number 18 is screening adolescents older than age 16. So even if there's no family history, an adolescent, especially one who's overweight or has insulin resistance, should be screened, and then screened every 5 years going forward. As always, we raise the issue of rule out secondary causes of dyslipidemia. This was recommendation number 29. again, a detailed history and physical, also review their dietary history, remembering to check glucose, thyroid, liver, and renal function. So a brief chart that we included reminding people, and don't forget anabolic steroids or progestins can affect their lipids. We often forget to ask about those. Certainly protease inhibitors with HIV infection. As I mentioned, thyroid. One thing that I get a consult at least once a year about is the effect of thiazides and beta blockers on lipids, and I can often cure them just by stopping those. Similarly, people who get started on estrogen or oral contraceptives can have abnormal lipids. Okay, so now I want to come back to this issue of extreme risk and how low can you go. And we introduced this target of extreme risk with an LDL target of less than 55. So what's the evidence for this? Starts with the cholesterol treatment trial analysis of intensive lipid lowering in patients with low baseline LDL in 2010. And what their conclusion of their meta-analysis was that even with people who have an LDL below 77, that if you can get a 39 milligram per deciliter reduction in LDL cholesterol, you have a 29% further reduction in events. Even if their LDL at baseline is below 70, for that 39 milligram per deciliter reduction, a 37% further reduction in events. So this is very important. Just because someone's down to 100 or down to 70 doesn't mean you've prevented all their events. There are a lot of people who still need further lowering, and that's what we're trying to highlight with this category. So in terms of looking at a meta-analysis of 8 trials of moderate to high-intensity dosing, what you see is as the LDL comes down from right to left, you have a decrease in the hazard ratio for major events. And if you look at our categories, here's our high-risk category, which is 100 to 125, very high risk, 75 to 100, and then our very lower risk, which would be coming into what we're targeting with extreme risk, is getting people below 75 and continuing to push to below 55. This chart doesn't just include LDL, but also the ApoB and the non-HDL cholesterol levels to give you a comparison. Now, moving on from there to the Improve It trial, which is another piece of data, where they did show a further decrease in events in people who were already low cholesterol. Their median LDL on follow-up was an average of 54 on the combination of ezetimibe-simva and 69.5 on the simvastatin alone. So with continuing to push further, and as I said, in this case below 55, you had a further decrease in events. So another piece of data to support the extreme risk category. And just looking at pre-specified groups and Improve It, who benefited the most from this further lowering of LDL? Women, those over the age of 65, those with diabetes, those on prior lipid-lowering therapies, and those with an LDL already below 95 were the ones who had significant benefits as a pre-specified subgroup. Now, a couple pieces of data coming from the PCSK9 therapies. And this is a study called GLAGOFF, which was an IVUS study using a PCSK9 antibody. And they looked at plaque regression as a function of therapy with this, the evolocumab, the PCSK9 inhibitor. And what they saw is that they could decrease the atheroma volume with this therapy. And the key is that the decrease in volume was a function of the LDL cholesterol. And what I want to draw your attention to here is the chart in the middle, that there was a continuous decrease in the volume that continued down to an LDL cholesterol of 20. They did not extend it below 120 because they didn't have enough people with levels below 20. But it's starting to raise the question of how low can you go, how low should you go? And although in the past they've talked about a J-curve with cholesterol, there was no J-curve here. So suggesting that the lower you can go with the LDL, the better. And then the last piece of evidence, which was actually completed and published after our guidelines. We didn't know what Fourier was going to show. This was presented at ACC and simultaneously published in the New England Journal of Medicine. And this was a randomized double-blind placebo-controlled trial using the PCSK9 inhibitor and with high-intensity statin compared to high-intensity statin alone. This is over 27,000 individuals. This is secondary prevention because they have clinical evidence of atherosclerosis. Their baseline LDL had to be below 70. They remained on statin therapy plus or minus the PCSK9 inhibitor. LDL levels dropped rapidly to approximately 40 and remained there throughout the study. And then at the end of 26 months, with the, as they described it, extremely tight control, you had a decrease in the primary composite endpoint and in the secondary composite endpoint, meaning MI, cardiovascular death, stroke, coronary revascularization, hospitalization for unstable angina. So adding this on top of a statin in people with LDLs above 70 gave you a significant decrease in events. And this is showing you the charts where on the left is the primary endpoint and the second is the key secondary, which is really your typical MACE of cardiovascular disease, MI, or stroke. So over 27,000 people in this study showing a benefit of decreasing the LDL down to 40 over 26 months or longer. There's a sub-study of that, of Fourier called Ebbinghaus, and it was looking to make sure there was not any neurocognitive problems. And the bottom line is with sophisticated testing, they did not find any memory, neuropsychiatric, or neurocognitive issues. So in terms of goals, I mentioned to you that we have the different categories. They're mostly grade A, evidence level 1, and this is the chart that just summarizes the categories and what the targets are. So extreme risk is an LDL below 55 with a non-HDL cholesterol below 80 and an ApoB level below 70. You can compare that to the lower categories, which are the risk categories you're accustomed to. And just to remind you, with children and adolescents, an acceptable level is below 100, and you want to question if they're above 130 on their LDL. And as I mentioned before about screening, and we do have good evidence in terms of the treatment of the children and adolescents. Similarly, with respect to women, I mentioned about the question, and I just want to remind you that they should be screened and treated aggressively also. And lastly, I came back to triglycerides, reminding you that as always, you should address triglycerides if they're above 500, and that our goal is to have them below 150, and ACE does specify that as a goal. It's not one of those amorphous things of this would be normal. We actually put it as a goal. So I mentioned the lipid treatment goals there. I wanted to get to one more slide before I finish. This is summarizing the different categories again. And in terms of treatment, this is to remind you that lifestyle intervention is still the foundation of your therapy, regardless of the person's risk, regardless of their LDL target. And then we have quite a number of medications I'm not going to go into in this talk, but just to remind you that lifestyle is physical activity, medical nutrition therapy, and smoking cessation. And then in terms of treatment, I included in my handout, and this will be on the website after the conference, just some comments with respect to statins to remind us about statin intolerance, and also to remind us about the typical doses of the statins, the dose ranges that you can use. And then also the benefit of using statins, again, going back to the cholesterol treatment trial, is collaboration. So, and then this is one last chart to give you approximately what decrease you should expect from each of these doses of statins. Again, this will be in your handout on the website. And then the other issue is just to remind people about monitoring, that you should recheck the lipids about 6 weeks after you've made a change, and once they're stable, check them once or twice a year.
Doctor, your time is up.
That's okay, I was right at the end, because the last slide was just to remind you the two issues are the category of risk, the extreme risk, and then the other one is the type 1 diabetes. No, it's fine. Let's just go to the last slide. There's just a couple more. And I wanted you just to see my reminder that type 1 is separate from type 2, that we recommend the use of combination therapy if needed, and your triglyceride therapy should be initiated if they're above 200. I put on here my email address. As I mentioned, the PDF will be on the website. If anybody actually wants a copy of these slides, send me an email and I'll be happy to send them to you. And then also here is the web link to get the PDF for the lipid guideline. Thank you very much.